Thanks very much, Bill. When you say 2 decades, it makes me feel old. So I'm going to give you some background to pharmacogenomics, and because it's an educational session, many of you might have heard this, and I apologize for that, and then give you some case studies in different areas. Some of it is our work, but also work other people have undertaken. So if you look at what we do in terms of prescribing drugs at the moment, there's a great deal of variability in efficacy to drugs, and it's well recognized that the vast majority of drugs, more than 90% that we use at the moment in our formularies, only work in 30 to 50% of people. And you give drugs, it's a trial and error approach. If it doesn't work, you try the second drug, trial and error, try the third drug, etc. All that time, the patient may be getting worse, and obviously you're also using up a lot of money trying these drugs out. There's also the issue of adverse effects, the toxicity of drugs. 6.5% of all hospital admissions are related to adverse drug reactions, and 15% of patients in hospital, admitted for other reasons, get adverse drug reactions. And in the UK National Health Service, when we extrapolate that to the whole bed base of the National Health Service, 8,000 NHS beds at the moment are occupied by patients with adverse drug reactions. So a typical NHS hospital in the UK is 800 beds. So that's 10 800-bed hospitals at the moment occupied by patients with adverse drug reactions. And the cost to the UK healthcare system is about £1 billion per annum. So it's a major issue that we need to be able to tackle to be able to reduce problem of iatrogenic disease. Now, what are the factors that lead to variation in efficacy and variation in safety? Well, obviously, there are going to be many different factors. Some will be environmental, some will be clinical prescribing, for example, and interactions and so on. So we don't actually know the overall genetic contribution to drug response. Some people have suggested it's about 30% of all variation in drug response may be genetically mediated. However, that is very much an estimate, and it's likely that a contribution will vary according to which drug you're looking at and which adverse effect you're looking at. Some of it may be completely environmental, some of it may be completely genetic. But what we need to understand is, as we move forward, is that we don't only look at the genetics, we actually look at the environment, and we try to put it all together. And that's the best way to be able to prevent adverse drug reactions as well as improve efficacy of drugs. And so one way of being able to understand and try to improve drug response is through pharmacogenetics or pharmacogenomics. So just a bit of history in terms of pharmacogenetics. Pharmacogenetics was named by a German pharmacologist called Friedrich Vogel in 1957. And although his definition was slightly different, I'm just quoting the definition from the International Conference on Harmonization, November 2007. And they basically said there was study of variations in DNA sequence as related to drug response. And clearly, as we know, that 99.9% of our human genome is exactly the same, but 0.1% is different, which relates to the pharmacogenetic differences. Now, pharmacogenomics is a term coined by Marshall in Nature Biotechnology in 1997, and this is looking at more the whole genome rather than individual genes, but it also includes RNA and DNA according to the ICH classification. So what is it that determines variability in the way we respond to drugs, and where might we find genes that are important? Well, you can divide it basically into two categories, pharmacokinetics and pharmacodynamics. And pharmacokinetics is basically what the body does to the drug. So with pharmacokinetics, you first of all have absorption, and there may be active processes of absorption such as transporters. You get binding to proteins in the bloodstream as it's distributed from the gut to the different organ systems, and again, there are genes that are involved there. Once you finish with the drug is metabolized largely in the liver, but also in many other organ systems, and again, P450 enzymes, etc., are all genetically polymorphic, and then finally you have to get rid of the drug from the body or the metabolites. And again, the excretory mechanisms may be genetically mediated. And all of that is termed pharmacokinetics, but it can be determined, the variability in pharmacokinetics between all of us in this room could be determined by the environmental factors, what we eat, drink, genetic factors, and disease also affects all of this as well. So it becomes quite complicated to try to tease out what the genetic importance is. Now, pharmacodynamics is what the drug does to the body, and drugs act on major targets in cells or organs, and these include receptors, ion channels, enzymes, DNA, etc. And again, these vary. And we know less about the pharmacodynamic effects of drugs than we do about the pharmacokinetics of drugs. And as we go to more unbiased approaches such as genome-wide association studies, next-gen sequencing, we're learning much more about the pharmacodynamic aspects of drug response because the pharmacokinetics were much more amenable to kind of candidate gene approaches that have been adopted since the time of early 1990s. And again, these pharmacodynamic effects can be determined by environmental factors, genetic factors, and disease can hugely impact on pharmacodynamic effects as well. So if you look at personalized medicine, and pharmacogenomics is one aspect of personalized medicine. So what we do at the moment is very much treat disease on the basis of phenotypic definition. And these phenotypic definitions have been around since the 19th century and the 20th century. And when we say it's hypertension, we say, we treat as a phenotypic definition. But as we move forward and learn much more about the molecular basis of disease, and that was clearly highlighted in the symposia yesterday, we start developing molecular definitions of disease. And as we move forward, it is likely that the taxonomy of disease will change. And we will be able to say it's not only hypertension, there will be hypertension subtype A, subtype B, subtype C, etc. So we'll be stratifying disease, and you can actually target therapy to different strata of disease as well, and that may be part of the personalized medicine that goes forward in the future. But even when you actually have individual strata of disease, and then use a particular drug between different individuals, you will still have variability in that drug, and this is where pharmacogenomic variation comes in. And finally, and this is going to be the most difficult aspect to be able to understand and take account of, and people call it the exposome, is to take into account environmental factors and how they affect drug response. So to go from the bottom where we are at the moment and take into account some of the things which are happening here, to go right to the top of this pyramid is going to take a lot of effort, a lot of work, and certainly there are areas where we have succeeded, and I'll show you some case studies, but there are many areas where we haven't, and so it does require a global effort to be able to undertake some of this work. So although the term pharmacogenetics was coined in 1957, in fact pharmacogenetics is probably much older than that. And it stems back to the work of Pythagoras. Now, Pythagoras was a polymath. He wrote many things. And if you have a quiet Sunday afternoon, and that's what I had, so I decided to do some Googling on Pythagoras and find out why he wrote these kind of things. And one of the things he wrote was that be far from fava beans consumption. And there are many theories about why he said that. One of the theories is that these look like testicles, and he certainly didn't want to eat testicles. But there may be other reasons, and he held this belief so strongly that he met his death in ancient Italy, in Cretonia, because he refused to cross a field of beans as he was being chased by some rival army. Now, the reason for his writings is because of favism. Now, favism occurs in certain Mediterranean populations, and in those particular populations, eating fava beans can cause red blood cell hemolysis, renal failure, and death in the most severe circumstances. And we now know that is because of a deficiency of glucose 6-phosphate dehydrogenase. Now, this is the most common human enzyme deficiency in the world. And this is not only relevant to foodstuffs such as fava beans, but it is relevant to drugs. And many of the drugs some of the drugs we use in the formulary, such as antimalarials, are certainly relevant for G6PD. So here's an example of a drug which was developed to treat malaria. It had a combination of clopropranol and dapsone, and it was called Lapdap. Now, it was highly effective, but very cheap, only 1 cent a day. And in Africa, you need to be able to get antimalarial very cheaply to the population. Unfortunately, because of some particular mutations in G6PD, which were prevalent in the African population, some patients started developing hemolysis when the drug was introduced. And that was because of dapsone in there, and that led to lower hemoglobin in these patients, and eventually led to the withdrawal of this drug, largely because at that time, and even now it will be difficult, there was no way of being able to genotype those individuals in the field with the lack of resources within Africa. So here's an effective drug which is lost at the moment. It may be able to come back in the future, depending what happens with malaria treatment and vaccines, because we may be able to identify patients with that G6PD deficiency and stratify therapy. So it's relevant to the present day as well. So in terms of case studies, I'm going to take you through 4 different areas. First of 3 different areas, sorry: efficacy, dosing, and safety. And I'll go through all those and give you some examples of where there is implementation going on at the moment in terms of pharmacogenomics. And clearly, efficacy and precision medicine, pharmacogenomics, then you have cancer therapy is clearly hugely important and is a poster child of pharmacogenomics to some extent. This is an example of chronic myeloid leukemia, where you have BCR-ABL translocation, which has led to the development of tyrosine kinase inhibitors such as imatinib, which have been hugely successful. And CML, which was previously a disease with poor prognosis, is now treatable, and many patients are living for many more years. And in fact, what people are thinking about is now that patients have been on this for many, many years, whether they should be taking them off the drugs or reducing the dose of imatinib plus the other tyrosine kinase inhibitors, and therefore the patients become drug-free after being treated for several years. So that's a hugely important step that occurred, and which has been transformational and really about to go to the next stage of actually taking patients off the drug, in effect a cure in a disease such as this. And obviously, if you look at Mary Relling and Bill Evans' review article in Nature in 2015, they nicely highlighted all the different genetic abnormalities in the different tumors, and what the driver mutations were, and all the drugs that have been identified that are available now to be utilized. The use of these drugs, to some extent, is still relatively low, and because of cost, because of ability to genotype, etc., and so on. But I think one particular area which really I was impressed with was what happened in France, and this was published last year. And what they did in France was that they took, over 1 year, all patients with non-small cell lung cancer, and they screened them for various different mutations in lung cancer. And this wasn't a small-scale effort, it was a huge effort. 17,644 patients in France in 1 year to be able to do that through regional genetic centers. And what they were able to do, based on the results, was directly affect the care of those patients. And they effected first-line treatment for 51% of patients who had those particular somatic mutations. And they showed, when they followed up these patients, that the presence of a genetic alteration was associated with better outcomes, as you can see on the slide. Now, the effect overall is small still, 4 months or so, in many of these outcome measures. Nevertheless, relevant for patients. 4 months is important for patients. But nevertheless, it gives us an idea of how to take it forward to the next stage. Now, these kind of mass studies, looking at whole population and how you can implement this, are very few and far in between. And certainly in France, they've managed to do it. I know it's going on in many other areas throughout the world, but certainly more work needs to be done in this area. Now, clearly, you can get efficacy in pharmacogenomics in other areas, non-malignant diseases, and cystic fibrosis is now an important paradigm as well. All of you, since this is a genetics conference, will know exactly where the mutations are for cystic fibrosis on chromosome 7 and the delta 508 being the most common polymorphism. Now, if you look at what these different mutations do, the mutations in CFTR, there are many different types of mutations which lead to different functional consequences. There may be no protein, or there may be no trafficking, or the protein is formed, and delta 508 is the commonest, is that you form it, but there's no traffic into the cell membrane. Then there are other types of mutations, such as G551D, where you do form a protein. It is trafficked from the endoplasmic reticulum to the cell membrane, but when it gets to the cell membrane, it's not functional. And then there are other types of mutations where there's less function or less protein or decreased stability. Now, work which has been ongoing in this area, particularly undertaken by Vertex Pharmaceuticals, has led to development of drugs, particularly for these two categories, Category 2 and Category 3. And Category 3 particularly has been highly successful in terms of taking that forward. And these are the two individuals who were able to develop a drug called ivacaftor. Here's the structure of the drug. And this targets the G551D mutation, which is the one that prevents, which does traffic to the cell surface, but is inactive at the cell surface and affects 4% of CF population. Now, they undertook a massive amount of work, 200 scientists looking at 600,000 compounds with in silico screening of 2.7 million compounds, tell you the scale of work that you have to do to identify particular drugs, and they were able to identify ivacaftor. Now, this has been shown in clinical trials, but also in clinical practice to have a fantastic effect in these patients with increases in the respiratory outcome measures, such as forced expiratory volume, about 10%, which is much better than gene therapy has ever achieved in cystic fibrosis. The importance of this also, and to show you why this is important, is that if you know the mechanistic basis of the mutation, i.e. it is the protein is non-functional on the cell surface, you can actually look for other mutations which may have the same effect as well, and that's exactly what has happened. And if you look at all these other mutations, these have the same functional effect, that you have the protein on the cell surface which is not effective. And in fact, the indication was expanded in 2014 by the FDA and the European Medicines Agency to include these different mutations as well without having to do a clinical trial. And that's the important thing, is that although there was a clinical trial for G551D, this doesn't need a clinical trial because they're using the same paradigm based on the mechanistic properties of the mutation. Now, you don't necessarily need, obviously one of the issues with this particular drug is the cost. And I think in the UK, the cost is about 120 to 150,000 pounds per patient per year. And that is a huge cost, but it doesn't necessarily need to be a high cost for things you identified. And this, I like the example of this particular syndrome, Brown-Vialetto van Laere syndrome, which you guys may know better about than I do, childhood motor neuron disease, characterized by many neurological problems, deafness, speech, swallowing problems, etc. It's only 60 cases in the world, and it's a rare autosomal recessive disease. Exome sequencing identified mutations in two transporter genes, SLC52A2 and SLC52A3. Now, these particular transporters transport riboflavin, which is vitamin B2. Now, because it's a vitamin B2 transporter, people have used high-dose riboflavin, vitamin B2, to be able to treat these patients. And there are now prospective studies, you can't do randomized controlled trial here, which have shown that some patients' progression of disease has been halted and some patients have improved. And I guess the issue is that how early do you treat? And if you can identify it early, then if you could treat the patients from early on, will you prevent any of the neurological deficits occurring at all? These kind of studies are going on at the moment. So, and clearly riboflavin is there that can be bought from drugs, can be bought over the counter, and it's not very expensive, and here's an example of how you can actually treat diseases such as that. Now I'm going to go on to dosing. Now Paracelsus in the 16th century, 15th century said that poison is in everything, no thing is without poison. The dose is what makes it either a poison or a remedy. Now you would have thought that in the last 500 years or so we might have learned from this, but unfortunately we haven't. What we do is we tend to use dose as equivalent to exposure, but we know that dose is not equivalent to exposure. And this is clearly shown here with one particular drug. It's an antiretroviral, but it doesn't matter, it can apply to any drug. And even if you give a fixed dosing and you look at different individuals, you'll find massive variation in the exposure. Some patients with having very high exposure, likely to get toxicity. Some patients having very low exposure, getting lack of efficacy. And it's important that as we move forward, we take into account dosing and exposure and try to develop precision dosing approaches as part of precision medicine to be able to improve the outcomes for our patients. And pharmacogenomics plays an important role here. So here's an example of eliglustat, which is used or has been licensed recently for the treatment of Gaucher's disease. Now, eliglustat is metabolized by cytochrome P452D6, which is absent in about 8% of the Northern European population. And this company, which licenses, was able to do pharmacokinetic modeling, was able to show that those individuals who were poor metabolizers for cytochrome P452D6, that's 8% of the population, had much higher levels exposure compared to those who were extensive metabolizers. And what they went to the FDA with and to the EMA is to say that they wanted a lower dose in those who were identified as poor metabolizers. So the label at the moment says that poor metabolizers, and you have to genotype patients to get the poor metabolizer status before you give them the drug, require 84 milligrams once daily, and extensive metabolizers require 84 milligrams twice daily. So I'm going to take you through another example which we've been working on, which is warfarin. Warfarin is an anticoagulant used in 1% of the UK population. The problem with warfarin is that you can either require 0.5 milligrams a day or 20 milligrams a day, so it's 44 variability in dose, and we can't predict that we couldn't predict that at the beginning. And if you get it wrong, you get bleeding, as in this patient. So work which has been undertaken by many people across the world, including ourselves, and this is showing data from UK prospective cohort study on a GWAS, was able to identify that there are two main genetic risk factors: cytochrome P452C9, which accounts for 16.5% of the variation in the UK population, vitamin K epoxide reductase complex, which is an enzyme inhibited by warfarin, accounting for 26% of the variation. So when you take all of this together, you can account for about 58% of the daily dose variation in warfarin dose requirements in the UK population. So working with a group of people throughout the world, but then refining it for the European population, we were able to develop algorithms and undertook a randomized control trial. And the randomized control trial was funded by the European Commission. And it was undertaken in the UK, and myself and Fahad Kamali were the co-PIs in the UK, and in Sweden, and Mia Wadelius, who's in the audience, was the PI in Sweden. And what we did was to randomize patients into genotype-guided dosing arm versus the standard care arm. The important thing was that we used a point-of-care test, and this was produced by a company called LGC, who were partners in the European consortium. What this did was to allow us to be able to get the genotype on 3 alleles in the 2 genes I showed you before in 2 hours. This was then plugged into a web-based algorithm which told us what the dose should be for those patients. And we were therefore able to compare the genotype-guided dosing arm versus standard care arm in relation to warfarin. And this paper was published, this randomized trial was published in the New England Journal of Medicine. And the primary outcome measure was the time patients were within the therapeutic range for the first 12 weeks following initiation of warfarin therapy. And if you can see the control arm, first of all, what they got in terms of time in range was 60% in the control arm, which is fantastic for current clinical practice, because you don't normally get that in usual clinical practice, but this was a randomized control trial, and we were able to follow up the patients much more closely. But despite this very good control in the control arm, we were able to beat that by achieving 67% TTR in the genotype down, which was highly significant. Now, when you actually get a result like this, people say, is it clinically significant? Well, we know that the effect was actually greater in those who had more than one variant or more than two variants, and that was about 11%. And we know from clinical data that a 10% improvement in TTR leads to 20% improvement in clinical outcomes. And we were also able to show that this was cost-effective. These are cost-effectiveness curves for the United Kingdom and Sweden, and these are the cost-effectiveness ratios. 6,700 in the UK and 253,000 Swedish krona in Sweden. And the threshold, these were below the threshold for cost effectiveness, and certainly, so we feel that it is cost effective in the UK. And so what we're doing at the moment in the UK is actually implementing this in local clinics in the northwest of England. So we're again working with LGC, which is the company in the UK. They've refined the platform. We now get the results on these 3 alleles shown at the bottom in 45 minutes. And this is being done by nurses. They get the mouth swab, they put it into the platform, and we get the results in 45 minutes, and it's put into a web-based algorithm. So that's where genetics, hopefully, is working in clinical practice and being implemented by peripheral anticoagulant clinics. So I'll go on to add the safety aspects and serious adverse drug reactions particularly. And I'm interested in patients who get very serious adverse drug reactions, for example, toxic epidermonecrosis, where the skin sloughs off. And in toxic epidermonecrosis, 30% of your body surface area blisters. And that's like having third-degree burns affecting 30% of your body surface area, or the liver rots away. What are the reasons for that? And these seem to be immune-mediated reactions, and we were particularly interested in the HLA. And HLA, as you know, the short arm chromosome 6, is the most polymorphic region of the human genome, and it is involved in, obviously, autoimmune diseases, fighting off infections, but it also predisposes patients to getting these immune-mediated serious adverse drug reactions. And we know that it's often T-cell mediated based on mechanistic work which has been undertaken. Now, the best example of how this has been implemented is with a drug called abacavir. Abacavir is used in the treatment of HIV, and it causes a hypersensitivity reaction in about 5 to 7% of individuals. Work undertaken by Australia, in the United States, and in northwest England was able to show that this particular HLA allele, 57.1, is highly associated with the abacavir hypersensitivity. We were able to show that if we were to implement this in the UK NHS, that it would be cost saving for the UK NHS. These data were used by HIV clinics in the UK, and in 2004 we published this. By 2006, every patient in the UK had B57.1 genotyping done when they were diagnosed with HIV and before they were put on abacavir. And that has had a dramatic impact on hypersensitivity reactions after the introduction of genotyping. Before genotyping, the incidence of hypersensitivity was 7%, and now it's less than 1%. And I haven't seen a case of abacavir hypersensitivity in my clinical practice for the last 5 years. And again, shows you how pharmacogenomics can work in improving drug safety. This is not just limited to abacavir. There are many other examples, and here's another example. And this came from Southeast Asia, where work undertaken in Taiwan was able to show a very strong association with carbamazepine-induced Stevens-Johnson syndrome or toxic epidermonecrosis and HLA-B star 1502. This has been replicated in other Han Chinese populations, in Thai populations, and in Malaysian populations. And when you put it all together in a meta-analysis, the odds ratio is 113. That means that anybody who's got this particular allele and is exposed to carbamazepine has a 113-fold increased risk of getting these Stevens-Johnson syndrome, toxic epidermonecrosis, than somebody who doesn't have this particular allele. And this is a hugely serious adverse drug reaction. So Stevens-Johnson syndrome has a 1 in 3 mortality. Stevens-Johnson syndrome has a 1 in 10 mortality. So it's important to be able to predict and prevent that. And now this is in the label. FDA and European label say that if you are of Southeast Asian origin, you should be genotyped for this particular allele before you give patients carbamazepine. Now, unfortunately, it doesn't end there. Since the beginning of the century, and we are 17 years into this century, there have been at least 24 different HLA alleles associated with serious immune-mediated adverse drug reactions. They range from those affecting the skin, those affecting bone marrow, liver, muscle, etc. And we can't possibly undertake randomized controlled trials for every one of these HLA reactions, HLA-mediated reactions, because they're relatively rare. So what we've been doing is trying to develop a gene panel which will be available for genotyping relatively quickly. You could undertake next-gen sequencing, but the problem with next-gen sequencing is that it will take much longer than the turnaround time you need. And our gene panel that we've developed with a company called Molecular MC Diagnostics uses their technology, which is called Mr. Spot, where you have wells and you have a single sequence-specific oligonucleotide spotted on the base of this, and it gives you a result on your laptop based on that. The idea behind this is that this will give us results within 48 hours, and it's been developed with the UK NHS. And for the UK NHS, this will be available for £30. A single HLA locus at the moment is available for much more than £30. It varies between different labs, but this will be available for £30 in the UK NHS for 48-hour turnaround time. And if you say, well, what does that gene panel mean? So we were able to undertake the analytic validation for working with this company. We looked at 187 healthy volunteers, and we sequence-based typed them for their HLA, and then we used the technological platform. We just developed the gene panel and looked at the number of risk alleles we identified. So only 15% of you in this room will not have any of those HLA risk alleles that I showed you before. About 20% will have one, and this poor individual one individual had 8 risk alleles that are on that gene panel. So 85% of people have at least one risk allele that leads to your increased risk of reactions. And the idea behind this panel is that you can order it when you need it for that particular drug, but you can actually store the data on your electronic health record, and it will be available for later as the patient grows older and requires some of the other drugs which are on this panel. But the important thing is that most physicians will not have the ability to interpret those HLA data. And so what we've developed in association with that is a clinical decision support system. And this is the front end of the clinical decision support system. You can actually, let's say I was going to prescribe carbamazepine to a patient. I would just click on this. If I clicked on carbamazepine, this is what would come up on the decision support system. It would tell me that there are 2 alleles associated with carbamazepine hypersensitivity, A3101, B1502. And then if I clicked on that, it will tell me all the different recommendations. Do I avoid the drug? Do I start the drug? If I start the drug, what do I do? So it provides help for the physician in terms of interpreting those very complex genetic test results. And although we've always focused on the fact in pharmacogenomics and drug safety that prediction is very important, and clearly prediction is very important, but there are other ways of being able to use genetic testing. And we highlighted this in a paper which has been published recently in January this year, showing that there's many different ways you can use genomic testing, not only for prediction. You could use it, for example, for diagnosis. If a genetic test has 100% negative predictive value, and you get a patient with a particular adverse reaction which seems to be related to the drug they were taking, but they are negative for this HLA allele, you can actually confidently say that the drug was not the cause of it. I won't go through this particular framework because I don't have time, but it's available and it's free online that you can download to be able to read it. Now, what I want to do is to finish off in the last 5 minutes on the big problems that are facing us in healthcare, not only in Western world, and not only in the Western world, but all over the world. Is that we have got changing demographics. Our population is getting older. And as you know, as you get older, you develop multiple diseases, unfortunately, and you get multiple organ systems affected. Not only, even if you don't have the diseases, as you get older, your kidney function deteriorates. So after the age of 40, you get 1% decrease in your glomerular filtration rate for every year as you get above the age of 40. So it's something for all of us to look forward to, I guess. Liver function gets worse, respiratory function gets worse, cognitive function gets worse, and you become less mobile. And all of those can affect the ability to handle drugs. In addition, as you're getting older, then you are going to go on more and more drugs. And typically, many patients that I see now in clinic who are above the age of 65 are on 7+ drugs. So you may say, well, how can genetics help us with that? And I'm grateful to Dan Roden for this slide. And he was able to do this in Vanderbilt and looked at the first 10,000 patients in a study called PREdict. And he was able to look at several different drugs and different polymorphisms. And he was able to then look at least how many of the patients had at least one high-risk variant and how many had at least one actionable variant. And when you put all of these 5 different drugs together, you find that a significant number of people, that is 91%, so 91% of you here will have at least one actionable variant in these particular genes here, and these are the very common drugs which are used in the population. So the idea behind this is that can you actually use these genetics preemptively to prevent these serious adverse drug reactions, improve efficacy, and so on. And in fact, one particular small trial has tried to do that. They said that we already have kidney and liver tests before we prescribe. What if we had genetic profiling? And what they did was that in patients over the age of 50 years who were on polypharmacy, they undertook a trial where they randomized patients, 57, to preemptive genetic profiling versus standard clinical care. And they were able to look at some clinical outcome measures such as hospitalization, emergency department visits, and a composite which included death as well. And they were able to show the pharmacogenetic profiling markedly increased these hard clinical outcome measures when you compare it to standard care. Now, this seems a huge effect size for such a small trial, but nevertheless, it is important pilot trial, if you like. And the important thing is to actually see whether this is relevant in a much bigger population. And this is what we're doing at the moment. This is I'm part of a Horizon 2020 U-PGX project, Ubiquitous Pharmacogenomics, U-PGX stands for. And the aim of this is to implement preemptive pharmacogenomic testing in real-world clinical settings across 7 EU sites. And Vita Dojan, who's in the audience, is also part of that in Slovenia. And the idea behind this is to evaluate patient outcomes using adverse drug reaction reduction as a clinical outcome measure and assess cost effectiveness. And this tells you the overall project outline, and there are 4 components to that. The first component, which is now finished, was to really develop enabling tools, which meant the information technology tools, the decision support systems that we can incorporate within our prescribing systems in 7 different countries, to have the pharmacogenomic testing platform, again, the same pharmacogenomic testing platform in 7 European countries, to be able to firm up and translate all the pharmacogenomic guidelines from the Dutch Pharmacy Association into many different languages, and also to have the training and education to be undertaken. Component 2, which I'll come back to, has a real outcome measure, clinical outcome measure, which is reduction in adverse drug reactions. We will also undertake look at process indicators. We won't mandate physicians to be able to change their prescribing because of a genetic test. We'll give them the data, and it's up to them whether they want to change it or not. If we find they don't want to change it, we want to understand why they didn't want to change their prescribing habit. And that's part of the secondary outcome measure. Cost effectiveness is also secondary outcome measure. Component 3 involves doing some hard science on there, doing some next-gen sequencing, particularly on outliers, looking at drug-drug interactions, and using systems pharmacology tools by measuring drug levels, incorporating that with genetics to identify why some patients got these adverse drug reactions. And component 4 obviously is very important, which is to disseminate our findings, to communicate our findings, as I'm trying to do at the moment, but also ethical, legal, and social issues. And this is component 2 particularly, and the component 2, we've called it PREPARE, which is preemptive pharmacogenetic testing for preventing adverse drug reactions. And this is like a cluster randomized study that we have 7 sites, and the first 3 sites are here, and these are highlighted with pictures, and Slovenia is part of the site which is starting off with pharmacogenomic guided prescribing. After 18 months, when we've recruited about 4,000 patients, you swap over. You go from pharmacogenetic guided prescribing to standard of care. While where I work, in the Royal Liverpool Hospital in the UK, we started off with standard care arm, and then after 18 months, we'll swap over to pharmacogenomic guided prescribing. And then what we're trying to do with this gene panel is to look at 15 genes, 48 variants, and that accounts for 42 drugs that we use within European healthcare systems. So I'll finish off by saying that how will pharmacogenomics affect people in the future? Well, there was a very nice talk about what's going to happen in the future. Well, it's always dangerous to try to predict the future, but it will be different. I think we'll be using many different forms of evidence in order to implement the innovations that are occurring into clinical practice. But we will need to use many different ways of being able to assess what we do to make sure that it is having an impact on public health. So just want to thank all the people who were involved in much of the work that I've shown you today. So thank you very much for your attention.